This video is for education and entertainment purposes only. Please consult with your healthcare provider before making any changes to your health. Hey beautiful soul, it's Jacqueline here from the Lost Labia Chronicles, where I discuss all things lichen sclerosus. So if you have lichen sclerosus and are looking to empower yourself with information, find acceptance, and help reclaim your life, then please subscribe to this channel and keep on watching. And if you have a friend, loved one, family member with lichen sclerosus, and you want to learn more about the physical and mental health aspects of living with the disease so that you can better support them in their lichen sclerosus journey, then please also subscribe to this channel and share it with them. All right, so in today's video, I am going to be doing part 1 of an ongoing series where I discuss lichen sclerosus treatment options. So in today's video, I'm going to start by looking at 2 types of treatments. Namely, I'm going to look at topical corticosteroids and calcineurin inhibitors. In future videos, I will look at other treatments such as PRP, laser, phototherapy, etc. It is important to note that for this series, I am only going to be covering treatments that either I can speak to from lived experience or where there is evidence-based information. So I won't be discussing more experimental treatments that don't have any studies published in medical journals. Now that's just because I don't feel like it's ethically, it just doesn't jive with me ethically to speak on something that I either haven't experienced or don't know about because there's no substantial research out there. But if you do have a question about a particular treatment and I don't cover it and I don't know much about it, please reach out nonetheless, and maybe I can connect you with somebody that does have lived experience or that has some knowledge, and they could support you in that part of your journey. So as always, if you find the information in this video helpful, please subscribe, give me a like, and definitely leave me a comment if you have any questions that you want to ask. I'm always happy to take your questions. I love it when you share your experience. So if you want to share how a certain treatment is working or isn't working for you, please leave that in the comments. I'm always happy to hear from you. All right, so let's get on with the video. All right, so let's start with steroids. If you are unclear on what lichen sclerosus is, how it's diagnosed, etc., I highly suggest that you pause this video and go check out a previous video that I recorded entitled What is lichen sclerosus and is it serious? And there you're going to get kind of like the basics of LS, and that'll serve as a nice spring point into this current discussion. So I will leave a link to that video in the description box below, and I will also pop a card with that link either here or here on the screen. I haven't quite figured out which way they go. Somewhere on the screen that'll pop up, so definitely go check that out first. Once you're diagnosed, your doctor will put you on a treatment plan. Now for many of us, that treatment plan involves being prescribed ultra-potent topical corticosteroids. Often that medication is clobetasol. The generic name, which you may be more familiar with, is Tamivate. Pronunciation, not too sure on that one. I have clobetasol, so that's the one I'm more familiar with in terms of how to pronounce it. But yes, so you might be prescribed Tamivate. And another thing is that different folks may be prescribed a different steroid medication depending on the severity of their LS. So while clobetasol is probably the most commonly prescribed, some healthcare providers will base the potency of the steroid depending on how severe the case is. So if a patient comes in with a very mild case of lichen sclerosus, their healthcare provider might be more inclined to prescribe a steroid that's lower in potency than, say, clobetasol. Conversely, if a patient comes in with a very severe case of lichen sclerosus, they will be more than likely prescribed a ultra-potent topical steroids such as clobetasol, which is one of the strongest steroid options that you can use with lichen sclerosus. Okay, so now I want to talk a little bit about the side effects that come with using steroid medication. This is extremely important as many of us are concerned about how our medication will impact our overall health. What kind of side effects come with this treatment? What risks are there? It's important that we know the risks and the rewards so that we can properly evaluate what treatment plan is best for us and our bodies. Now, this is important to note. Well, it's important for me to note that what I'm going to be discussing in this portion of the video very much relies on side effects documented in medical literature. Now, this does not mean that these are the only side effects that one could experience from steroids with lichen sclerosus. Now, just because you may have a reaction and it's not documented in the literature, that does not mean that your side effect or your reaction is not real. And when you go to the doctor and report that side effect, they should take your concern or your reaction seriously and adjust your treatment plan accordingly. So again, if I mention something that you don't experience, that's totally okay. And if I don't mention a reaction that you've had, that does not invalidate your reaction or your experience. So I just want to kind of flag that, of course. Another thing to note is that I am discussing topical corticosteroids, which are different than an oral steroid medication that you would take. The oral steroid has systemic effects on the body, and a topical steroid or a topical medication is essentially a medication that is applied topically to the skin or to a part of the body. So in our case, we are looking at genital lichen sclerosus, then it would be applied to the vulva, applied to the anal region, or to the penile region. Okay, so now that I've got that little, kind of disclaimer out of the way, let's dive into some of the side effects. So I'm going to break this into two groups. One group is going to be general side effects, and the other is going to be specific to lichen sclerosus side effects. Okay, so the use of using long-term topical corticosteroids in general, i.e. not necessarily lichen sclerosus, includes things like rebound infections. So you have infection X, you treat, but then you just keep getting infection X again. So these are these kind of rebound effects from using the medication. There is also dermal thinning, so skin thinning can happen, and of course fungal infections can also occur with the use of long-term topical corticosteroids. These are documented in a paper by Goldstein et al. That's a 2011 paper. I believe it's 2011, but I will leave this link in the description box below. And as usual, any research paper that I am citing in this video will be linked in the description box below. So I, of course, always encourage you to go to the source, do your own research. Don't take my word, don't take anybody else's word. If you're the type of person that likes to go directly to the source, of course I encourage that if it feels supportive and empowering to your lichen sclerosus journey. So what are the side effects of using topical corticosteroids for lichen sclerosus? So these are the side effects that have been documented specifically in cases of folks with vulvar lichen sclerosus. So one side effect that is known is yeast infections, recurrent yeast infections. Now, this is typically controlled by preventative antifungals such as nystatin, which can be prescribed either orally, topically. Some folks actually have their steroid medication compounded with nystatin. So instead of needing to apply two different creams or ointments, they can just apply it in one shot, which just makes it honestly a lot easier. I mean, we already have so many things to kind of focus on with respect to our treatment plan and symptom management. If you can avoid having one more cream, let's do it, right? Okay, so that is one side effect that is documented with lichen sclerosus and steroids. The second one is arrhythmia, which is essentially like a skin rash. And this is typically controlled by your healthcare provider reducing the potency of your steroid or the frequency with which you use your steroid. The last commonly known side effect is stinging and burning after applying your steroid ointment. And this is typically something that will resolve within a couple weeks. Normally the reason for the stinging and the burning is that there are fissures and cuts that haven't healed yet. So typically when, it was shown that people were reporting stinging, this tends to resolve within 2 weeks or so. If it doesn't, definitely talk to your healthcare provider. I do want to also note that in this case with burning and stinging, it is important to know that not all bases are equal. So let's just use clobetasol because it's just an easy one for me to go to. But any steroid, such as clobetasol, it sits in a base, right? So I believe for clobetasol, mine is compounded in petroleum jelly, I believe. I'm not too sure. I'd have to go check the label. But essentially, they can come in creams or gels or ointments. Now, the problem with the cream is that these creams have alcohol in the base. Now, if you have a fissure or an open cut, as you know, like if you've ever cut yourself and put rubbing alcohol on it, what happens? It burns. So similarly, if there's alcohol in the cream and you're putting that and you have open cuts and fissures, it will burn. So if you're having this and you are on the cream, it is advised that you ask your healthcare provider to switch you over to an ointment, which does not have any alcohol in the base. So it's a lot more gentle on the area. So those are the 3 most commonly documented side effects that come with using your steroid and lichen sclerosus, most of which healthcare providers have something they can do to work with it, to kind of alleviate or even better, eliminate that side effect. And this is from Dr. Lee and Fisher. I will again link their paper in the description box below. Now, many folks worry about skin thinning, and I did mention that in general, it is reported that the use of topical corticosteroids can lead to skin thinning. But it's really important that we note that those papers were not looking at folks with lichen sclerosus. And this is key because lichen sclerosus skin is very different from non-lichen sclerosus skin. So I'm going to go into those differences and address a bit of the concern about steroids causing skin thinning. Okay, so I definitely want to touch on the difference between lichen sclerosus skin and non-lichen sclerosus skin and how this impacts the concern of skin thinning. So there are actually a couple studies that have been published that look at the effects of topical corticosteroids and skin thinning and skin atrophy. Both of those studies found that when the steroids are applied to lichen sclerosus skin, there was no thinning and no atrophy shown. I discussed those 2 studies in an ebook that I wrote. It is free. I will leave the link in the description box, but you can go to www.lostlabia.com/ebook to get your copy if you want to kind of read more about those studies. I'm just kind of giving you the Coles Notes version. So those studies found that when it was actually applied to lichen sclerosus skin, these concerns did not actually manifest. So now I am going to pop up a little screen cap. Feel free to pause the video and read through it, take a screenshot. I'm essentially going to go over how skin is different in lichen sclerosus patients compared to non-lichen sclerosus patients. So patients with vulvar lichen sclerosus, the average stratum corneum, which is that outer layer of skin, that thickness is approximately 1,200 millimeters. Now, this is over 7 times thicker than the average stratum corneum of non-lichen sclerosus skin. And this information comes from a paper from Pfau et al., which was published in 2021. So again, because our skin is different than non-lichen sclerosus skin, the impacts and side effects are going to be different. I do address the question of whether LS causes skin to thin or thicken, and I will leave a little card somewhere where you can tap and go watch that, or I'll leave it in the description box if you want to see that video. But essentially, lichen sclerosus causes our skin to get really thick. And for this reason, our skin is just qualitatively different than non-lichen sclerosus skin. So thus far, these thinning side effects, thinning atrophy, have not been seen when used properly on lichen sclerosus skin. So how do topical corticosteroids work? Well, essentially they work by reducing inflammation in the vulvar area or in the genital area. So, and I mean, trust me, lichen sclerosus turns out a lot of inflammation. It is the single most inflammatory chronic skin condition that you can have. So it is absolutely crucial to control the inflammation in order to control and manage the disease, because our symptoms, and like our symptoms such as itching and pain, tearing, and things also like our anatomical changes such as fusing of different parts of the vulva. This is all caused by changes to the skin that occur because there are high levels of inflammation in the basement layer of your skin. So we control the inflammation, we control the LS. So it is crucial that no matter which treatment plan you are choosing, you opt for something that targets that inflammation. So I am going to now pop up another thing on the screen, which is going to be a diagram from an incredible paper by Pfau et al., which was published in 2021. Highly recommend this if you want a deeper dive into the science and biopharmaceutical kind of background of steroids. Definitely check that out. Okay, so we're going to pop that up now. Okay, so in this visual representation, they kind of explain how topical steroids are absorbed and metabolized, as well as the result they elicit. And that result is ultimately creating a lowered inflammatory response. All right, so in the scientific literature thus far, what are we? February, I don't know what date we are. We're February something. 2022 at the time that I'm filming. So thus far, they are unmatched compared to any other treatment option in terms of reducing that inflammation. Now, of course, this is 2022. There are multiple different treatments being studied right now in various stages of clinical trials in the pipeline. There may be future treatment plans that are even more targeted than the steroids, and that's fantastic. And I hope that one day I can have a video on that. Maybe one day I will be posting a video that we have found a cure. That would be fantastic. But as of today, it is really, they are the gold standard in treatment, and other treatments are typically explored when a patient is not reacting to or is unable to tolerate topical corticosteroids. And in closing, in closing for the steroid portion, I do want to note, and I'm going to insert a video kind of scrolling through, when we talk about steroids, know that if one steroid doesn't work for you, that doesn't mean that that's the end of the line. There are a multitude of steroid ointment options out there that you can try, and they all there are different levels of potency. So your LS may require a mid-potency or even a low-potency steroid. I know folks with mild cases that treat and maintain with a low-level steroid. So I'll kind of pop that video up so that you can see that there are a ton of options. So if one option doesn't work for you, don't be too discouraged. Know that there are other options out there for you to explore. Okay, so here is a website that breaks down the different steroid options, and it breaks them down in terms of their potency levels. So we can see here the super high potency, we have betamethasone and clobetasol. It also shows you what vehicle it is delivered in, so whether it's an ointment, gel, lotion, cream, etc. It gives you the brand name and the percentage of the strength. So if we scroll down here, then we have the high potency, the different groups. We have the medium potency ones, the lower to mid potency, as well as some low potency, and then the least potent one, which is hydrocortisone. So as you can see here, there are quite an abundance of options. There's a bunch of different options per group depending on the potency that you are looking for, as well as the base that you are looking for. I did mention that the cream typically comes with some alcohol in the base, and so that can be really irritating if you have any active sores or fissures, and so you might want to opt for an ointment form. Some folks don't have any reaction to the base, but they just prefer a certain texture. So some folks find the ointment too thick and they prefer to have their steroid delivered in a gel format. Totally okay. You find what works for you, and that's a discussion that you can have with your doctor as well as your pharmacist, especially if you want or need your steroid compounded, which some folks do need their medication compounded because they are allergic to something in the base. So that is also something to be mindful of. If you have a reaction, an allergic reaction to your steroid, definitely mention that to your doctor and see if they can compound it into an allergen-free base at a compounding pharmacy. All right, so let's talk a little bit about calcineurin inhibitors. So calcineurin inhibitors are non-steroidal immunosuppressant cream-based medication. Most frequently, the two main ones that are prescribed are pimecrolimus and tacrolimus. We'll leave some little images here. Of course, these can vary depending on the country that you live in. You might be prescribed a different calcineurin inhibitor, but essentially they all work to suppress the immune system, which consequently lowers inflammation. Again, as I mentioned before, lowering inflammation is really key to managing and keeping the LS in check. So that's super important. Okay, I now want to move into what does the medical literature say about calcineurin inhibitors. A double-blind randomized controlled study by Goldstein et al., which was published in 2011, looked at a group of 38 patients with vulvar or biopsy-proven vulvar lichen sclerosus. Now, the purpose of this study was to determine whether and to what extent calcineurin inhibitors were effective in treating lichen sclerosus. Now, in order to address this question, they divided this group of 38 patients into two groups. One group had 18 patients, and they treated with pimecrolimus, which is a calcineurin inhibitor. They treated for 12 weeks. And then the other group contained 20 patients who treated with clobetasol, so a steroid treatment, for 12 weeks. The main measure to determine whether and to what extent these treatments were successful was the comparison of pre and post treatment biopsies. So a biopsy was taken before they treated, and then after they did those 12 weeks of treating, whether it was calcineurin inhibitor or the steroids, another biopsy was taken. Now, these biopsies were evaluated by an expert dermopathologist who was also blinded. So the biopsies that they received, they didn't know which group that came from, the calcineurin inhibitor group or the steroid group. The patients were also blinded, so the patients had no idea if they were treating with calcineurin inhibitors or steroids. And secondary measures also included any changes to symptoms. So if anyone reported like, I had super bad itch, but then after the 12 weeks, I had no more itch, that was something that would be evaluated as well. And there was also a questionnaire that was included as secondary measures. What they found was that both calcineurin inhibitors, so the pimecrolimus and the clobetasol, were both effective in reducing the inflammation, and this was seen on the after biopsy compared to the biopsy that was taken initially. However, the authors did note that clobetasol had a stronger or higher reduction in inflammation. Therefore, they conclude that steroid treatment should continue to remain the first-line treatment for folks with lichen sclerosus. However, for those that do not tolerate steroids, or for folks that don't want to use steroids, this should be considered a second-line treatment that is proven to reduce inflammation. And before wrapping this section up on calcineurin inhibitors, I do want to note that one of the main side effects from calcineurin inhibitors is that they sting and they burn. I have never used them, but what I've heard from folks that do use them is that they do sting initially. Most folks have told me that it kind of goes away in time, but like at least initially it's really uncomfortable. And I've heard doctors say that as well. Doctors will say that they prefer to treat with steroids because they don't have that same intense stinging effect. So that is just a side effect to be mindful of. All right, thank you so much for sticking with me this far. This is the wrap up of my first video in the lichen sclerosus treatment series. So we went over topical corticosteroids, how they work, side effects, what the literature says. We went over calcineurin inhibitors, some side effects, and what the research says. Essentially, both treatments have been proven to reduce inflammation significantly. However, clobetasol or steroids do seem to have a slight edge and offer more reduction in the inflammation. So most doctors prefer to use steroids as the gold standard, the first-line treatment, and calcineurin inhibitors as second-line treatment, but they still do work to reduce that inflammation. All right, so that is it for this one. Thank you so much for watching. If you found this video helpful, please leave me a thumbs up. If you have any questions, if you have requests, treatments that you want me to go over or speak on, please leave those in the comments. Remember that if I haven't personally tried it and there's no medical literature out there, I don't feel comfortable putting out content because I really don't know much, but ask your questions nonetheless, because if I don't know it, I can probably connect you with somebody that is more of an expert in that area and that can help guide you in that sense. All right, so I will catch you in the next one. Bye.